Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very interesting topic, ischemic stroke, its pathophysiology. Ischemic stroke, its pathophysiology and the Hagen-Poiseuille equation. The three important causes, the three most common causes of death are myocardial infarction, stroke and cancer. And hence we need to know a lot about ischemic stroke, the pathophysiology of ischemic stroke. In fact, myocardial infarction and ischemic stroke, the pathophysiology is similar. Decreased blood supply to the heart and then decreased blood supply to the brain. So basically it is ischemia, the decreased blood supply to that particular organ. So what happens when there is decreased blood flow? What is the pathophysiology? And how can we salvage the ischemic penumbra where there is decreased blood flow, decreased perfusion, but still the area is not necrotic. It is still in the reversible stage but with decreased perfusion, the ischemic penumbra, where we can salvage the tissue by thrombolytic agents, TPA, tissue plasminogen activator. Right. So ischemic stroke, the pathophysiology. But what are the unique features of brain metabolism? What are the unique features of brain metabolism? The brain is susceptible to hypoxemia because it has got a limited intrinsic reserve of high energy phosphate compounds. It has got a limited reserve of high energy phosphate compounds. And second, it has got a high metabolic demand. Despite the brain weighing only 2% of the total body weight, the blood supply to the brain, the cardiac output is 20%. That shows the high metabolic activity of the brain which is involved. And then it needs a continuous supply of oxygen and glucose. So the brain needs a continuous supply of oxygen and glucose. Because of these unique characteristics, the unique features of brain metabolism, brain is vulnerable to hypoxemic and ischemic pathophysiology. Right. How do we explain the pathophysiology, the ischemic pathophysiology? It can be explained by a very important equation known as Hagen-Poiseuille equation. By using the Hagen-Poiseuille equation, we know the various parameters which affect the blood flow to the brain. So the cerebral blood flow is dependent on two important factors. Two important factors are determinate. The first factor is directly proportional to the cerebral blood flow. That is the cerebral perfusion. As the cerebral perfusion increases, so also the cerebral blood flow. But what is cerebral perfusion pressure? Cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So as the cerebral perfusion pressure increases, so also the cerebral blood flow. And the cerebral perfusion pressure is dependent on the mean arterial pressure and therefore the blood pressure. And therefore one of the important clinical points we need to remember here is that as soon as the person presents with ischemic stroke, we should not unduly lower the hypertension, because the body is trying to compensate. According to the Hagen-Poiseuille equation, the body is trying to compensate by increasing the blood pressure, to the brain, so as to increase the cerebral blood flow, because cerebral perfusion pressure is directly dependent on mean arterial pressure. So usually in clinical practice, we don't reduce the blood pressure at least for a couple of days after the person presents with the ischemic stroke, because the body is trying to compensate the ischemia by increasing the pressure and therefore the cerebral perfusion to the brain. And therefore for the first couple of days we generally don't decrease the high blood pressure, because the body is trying to compensate by increasing the blood pressure so as to maintain the cerebral blood flow. But if the person is already a known hypertensive and is taking antihypertensive drugs, he would be asked to continue the antihypertensive drugs as usual. The second important determinant, which is directly proportional to the cerebral perfusion, cerebral blood flow, is the vessel radius. The more the vessel radius, the more the cerebral blood flow. And hence, when we see in auto-regulation, where the brain tries to auto-regulate its cerebral blood flow, when there is decreased blood flow to the brain, the vessel dilates, the radius of the vessel increases so as to increase the cerebral blood flow. And when there is hyperperfusion or hypertension, the brain tries to reduce the radius of the blood vessels so as to decrease the blood flow to the brain. So the radius of the vessel wall is very important factor in determining the cerebral blood flow. The more the vessel radius, the more the cerebral blood flow. The less the vessel radius, the less the cerebral blood flow. So far we've seen two conditions: cerebral perfusion pressure and vessel radius, which are directly proportional to the cerebral blood flow. Two factors are inversely proportional or inversely related to the cerebral blood flow. One, the blood viscosity. Second is the vessel length. The more the viscosity, the less the blood flow, the sluggish the blood flow, and therefore there is a decreased cerebral blood flow. Again, the more the vessel length, the more the decrease of the blood flow to the periphery of the organs. The proximal parts of the vessel gets good blood supply, but as it goes to the distal parts, it does not get good blood supply. So the more the vessel length, the less the cerebral blood flow. And this concept is very much applicable to the clinical situation known as the border zone infarcts. Border zone infarcts are those infarcts which is present in the border areas between the main vessels, that is the anterior cerebral artery, middle cerebral artery, or middle cerebral artery and posterior cerebral artery. The border zone infarct of the anterior and middle cerebral artery, we call that as a man in barrel syndrome, because the shoulders, the hips, the arms are mainly affected, which is present in the border zone between the ACA and MCA. And between MCA and PCA, we call it as the balance syndrome, where they have asimultanagnosia, optic ataxia, oculomotor apraxia. So the more the vessel length, the decrease the blood flow. So when we take the condition like hypoperfusion, the proximal parts of the blood will get good blood supply. There is blood flow, but it is sluggish blood flow. So proximal parts get good blood supply, but as they go to the distal parts, the blood flow to the distal parts gets decreased, and therefore the vessel length and the blood viscosity are inversely proportional to the cerebral blood flow. So this is a very, very important equation by which we can explain the pathophysiology of ischemic stroke, the equation known as Hagen-Poiseuille equation. Right. Now, if a person comes with ischemia and ischemic stroke, are there any ways to modify this ischemia? Having understood that Hagen-Poiseuille equation, which determines the cerebral blood flow, if a person comes with ischemia, can we intervene and do something to modify the ischemia? Or the nature, the mother nature, is it trying to modify the ischemic factors so as to protect the brain from ischemic or hypoxemic damage? So what are the ischemia modifying factors? The first factor is collaterals. So because of collaterals, the brain is able to survive and is able to tolerate the ischemic conditions better. As I said in the beginning of my lecture, the three common causes of death are myocardial infarction, ischemic stroke, and cancer. The cancer is not related to the vessels. Basically, these two are related to vessel, that is atherosclerosis. Myocardial infarction, that is coronary artery atherosclerosis, or internal carotid artery atherosclerosis. Because of the excellent protection of the brain in the form of circle of Villus, the brain is able to tolerate hypoxemic conditions better. Otherwise, if not for the circle of Villus, probably the ischemic stroke would have been the commonest cause of death, superseding even myocardial infarction. But Mother Nature has given a wonderful protection to the brain to be able to withstand and tolerate the hypoxemic conditions better in the form of circle of Villus. Circle of Villus is a communication between the carotid artery system and the vertebro-basilar system. And therefore, when the vertebro-basilar system gets affected, since it's in the form of a circle, blood can come from the internal carotid arteries and can compensate the vertebro-basilar areas. Example, when there is a block in the vertebro-basilar artery system, blood can come from the internal carotid artery and posterior communicating artery. The posterior communicating artery communicates between the carotid arterial system and the vertebro-basilar system, and therefore if there is a block in the vertebro-basilar system, blood can come from the internal carotid artery via the posterior communicating artery and can try to salvage the tissue, salvage the hypoxemic tissue. So because of these collaterals, brain is able to tolerate the hypoxemic conditions well. So what are the collaterals? One between the internal carotid artery, that is the anterior circulation, and VBA, vertebro-basilar circulation, that is posterior circulation through the posterior communicating artery. We have collaterals between the anterior cerebral artery, middle cerebral artery and posterior cerebral artery. When the border zones get affected, we call that as border zone infarct. We have collaterals between the vertebral system, between the internal carotid artery and the external carotid artery system also. Because of these collaterals, if there's a block on one side, blood can come from the other vessels retrogradely and then supply the compromised area. So this is one of the most important ischemia modifying factors, that is collaterals. Second is that blood vessel dilatation, as I said, auto-regulation. When the blood flow to the brain starts getting decreased, brain is trying to compensate, somehow is trying to increase the blood flow to the brain by allowing the vessels to dilate. Arterioles, the capillaries, they start dilating. Because there is decreased blood supply, the blood vessel starts dilating so as to increase as much blood as possible to the brain. Only when this also gets exceeded, then person will develop hypoxemic or ischemic injury. The third ischemia modifying factor is that increased cerebral oxygen extraction. Brain tries to increase as much as possible the oxygen from the blood. So increased cerebral oxygen extraction. So the ischemia modifying factors, collaterals, the blood vessel dilatation and increased cerebral oxygen extraction. Only when these measures fail, beyond which still the blood is not able to flow, then you get signs of hypoxemic or ischemic brain damage, hypoxic encephalopathy. So these three are important modifying factors. If not for these important ischemia modifying factors, most of us would have had ischemic stroke. Despite having this excellent protection in the form of collaterals and ischemia modifying factors, still ischemic stroke is the second commonest cause of death. Imagine if this protection were not to be there, perhaps ischemic stroke would have been the commonest cause of death, superseding even myocardial infarction. Right. Now, there's an important concept known as ischemic penumbra. We've been hearing a lot of neurologists, physicians trying to salvage the tissue by thrombolysis, tissue plasminogen activator, TPA, altiplase. So what is this ischemic penumbra? So when there is decreased blood flow to the brain, there is a central tissue which completely gets affected. There's no blood flow to the central part of the artery, which you call it as a core tissue. So that is an ischemic core which is dead because there's no blood supply to the central part of the brain area. So when the central part of the area which comes under the territory of the artery gets affected, the brain is dead, which you call as ischemic core. But surrounding that ischemic core, though there is a decreased blood supply, the brain tissue is still surviving. It is in a reversible stage. It is affected by ischemia. There are some changes going on in the tissue, but still it has not gone to a stage of irreversibility. So this we call as ischemic penumbra. So this tissue only we are really concerned about, because we cannot do anything with the tissue which is already dead, the center tissue, the core, and the surrounding tissue, ischemic penumbra. We can do something, because though the perfusion is decreased, it is still salvageable, it is still reversible stage, and beyond that is the normal tissue where you will not do anything. So the three areas, the central core, you cannot do anything because it is already dead. The third, the outermost core, it is normal, so you will not do anything. We are only concerned about the central, the mid area between the normal and the ischemic core, which is known as ischemic penumbra, where the perfusion is decreased but the brain tissue is still not dead, it is in a reversible stage. So it is this area we are concerned about, and we initiate the thrombolytic therapy within 4.5 hours, the TPA or altiplase, so as to salvage the tissue. If the indications are good and there are no contraindication, and if we give the thrombolytic agents within 4.5 hours, the person becomes almost normal. The only worry is that if we go beyond the window period, there are chances of hemorrhage. So 4.5 hours is the window period, but the earlier we give, the better it is. So how do we pick up this ischemic penumbra radiologically? We can do MRI. We use a sequence known as diffusion perfusion sequence. So when the perfusion, that is the blood supply to the brain, is decreased, the entire area gets affected. But the entire area gets affected, the decreased blood supply. But the central core area, the diffusion is affected the most. But the peripheral area, the ischemic penumbra, though there is decreased perfusion, the diffusion is still present. It is still reversible stage. So ischemic penumbra is nothing but the MRI diffusion perfusion equivalent of perfusion minus diffusion. So the perfusion area minus diffusion area. So this area in between the perfusion and diffusion area, the perfusion diffusion mismatch, which we see in MRI diffusion perfusion sequence, is the MRI or the imaging equivalent of ischemic penumbra. So when we do perfusion diffusion scan and we find a mismatch between the perfusion and diffusion, it is the radiological or imaging equivalent of ischemic penumbra, where we can thrombolyze and salvage the tissue. Right. But what exactly happens when there is ischemia? What is the ischemic cascade? So once there's a reduction of the blood flow or the hypoxemia, the ATP gets decreased. So when the ATP gets decreased, the hydrogen gets increased, and due to anaerobic metabolism, the lactic acid also gets increased. So there is lactic acidosis. And one more important point is that generally in the cell, at the cellular level, the sodium is generally pumped out and potassium comes inside. How is it that the cell is able to keep the sodium out of the cell? Though the concentration of sodium is more extracellularly than intracellularly, still the cell is able to keep the sodium out against the gradient. How is it possible? It is possible because the sodium potassium ATPase pump, which pumps 3 sodium out and allows the 2 potassium ions inside. But when there is hypoxemia, the sodium potassium ATPase pump gets affected and the pump is ineffective in pumping the sodium out. So the sodium rushes inside, the influx of sodium increases. Along with the sodium calcium pump also gets affected, and therefore the calcium also comes inside the cell, and because of the influx of the sodium, water also comes along with the sodium, and therefore now there is an intracellular water accumulation called as cytotoxic edema. So this is cytotoxic edema because of the membrane function membrane pump dysfunction, that is sodium potassium ATPase pump dysfunction. Sodium enters inside the cell. Along with the sodium, water also enters inside the cell, and now there is a swelling of the cells, which is known as cytotoxic edema. So the calcium also enters. Now the glutamate, the neuroexcitatory substance also now gets activated because of the influx of the calcium. The glutamate also is, the neuroexcitatory substance is also increased. So vicious cycle starts happening. More glucose, more calcium entry, more glutamate production, more calcium entry, more glutamate production. So a vicious cycle enters and the glutamate starts increasing, which is a neuroexcitotoxic substance and disastrous to the cells. The next stage is that the lipases gets increases. Lipases digest and destroy lipids. So we have a cell membranes which is full of lipids, and therefore when the lipases are released, the lipases go and destroy the membranous lipids. We have lipids in the membrane, cell membrane, and therefore pores start forming, and therefore the toxic substances also enters the cell, and then it causes a real toxicity to the cells because of the break in the plasma lipids and entry of toxic substances into the cell. We also have an increase of proteases which starts digesting the proteins. Then there is an activation or release of free radicals which activate the procoagulant pathways and then further enhances the clotting mechanisms. Already there is ischemia. On top of it, there is a release of free radicals which activate the procoagulant pathways. And as I said, the glutamate which is released causes liquefactive necrosis. Liquefactive necrosis causing glial cell death and glial cell injury. So this is the ischemic cascade. So initially we are able to salvage and reverse, person becomes better, but slowly it goes to an irreversible stage where the glial cells finally die because of glutamate injury, calcium influx injury, release of free radicals, lipases, proteases which digest the lipid membranes and causes the toxic substances to enter from extracellular to intracellular spaces, and along with the sodium, water also enters from the extracellular to intracellular levels and causes cytotoxic edema and cellular swelling. Right. So how do we pick up radiologically? What are the neuroimaging changes in acute stroke? You can divide the neuroimaging changes into two parts. One, the visualization of the clot per se, the early change, and two, the parenchymal changes which occur later, usually 1 hour. First is the visualization of the clot per se, second is the parenchymal changes. In the visualization of the clot, there are two important findings we can pick up. One is the hyperdense middle cerebral artery site. When there is a blood clot, it appears hyperdense as compared to the flowing blood. The flowing blood has got a different HU as compared to the blood clot. Since the HU is different from the flowing blood, the blood clot appears in the middle cerebral artery, what we call it as a hyperdense MCA site. And second, on the top of the basilar artery, as the basilar artery also gets clotted, it also appears hyperintense as compared to the neighboring internal carotid arteries, what we call as a dense basilar artery site. So neuroimaging, we can directly visualize the clot, one as dense MCA sign and second as the basilar artery, dense basilar artery sign. And when we come to the parenchymal changes which appear 1 hour later, the four important changes we see are: one, the basal ganglia. The basal ganglia, especially the caudate and the lentiform, they are supplied by the lenticulous striate arteries of the middle cerebral artery. They do not have good collaterals. As I said in the beginning of the lecture, most of the hypoxemia can be modified because of the collaterals according to the Hagen-Poiseuille equation. But since the basal ganglia get lenticulous striate arteries from the MCA and which do not have good collaterals, they get affected first. The basal ganglia, the caudate and the lentiform nucleus. Second, the insular ribbon sign. The insula is very far off from the vessels, be it MCA or ACA and PCA. Since it is distant, it does not get good blood supply and therefore it also gets affected first. Here, as you see again, according to the Hagen-Poiseuille equation, the more the vessel length, the less the cerebral blood flow. So how this Hagen-Poiseuille equation can be applied for clinical conditions as well as radiological conditions, and how we are finding it useful. So basal ganglia gets affected, the insula get affected. Because of the cytotoxic edema, as I said, the gray matter, white matter differentiation gets affected, and the sulci and gyri, there is effacement of sulci, it becomes almost equal. So these are the four important changes. One, the basal ganglia gets affected because of the less collaterals. The insula gets affected because of the length, the distance from the actual vessel, and it is getting poorly perfused. Because of the cytotoxic edema, there is a differentiation of gray matter and white matter is lost, and there is effacement of sulci. These are the changes which we see in parenchyma, which appear a bit later, 1 hour later. But the earliest findings which we see is the direct visualization of the clot in the form of hyperdense MCA sign and hypertense Bessler artery sign. Generally, when we talk about the metabolic conditions and structural conditions, we say structural conditions are focal, metabolic conditions are generalized. True, but not all areas of the brain are equally susceptible to metabolic changes. For example, hypoxemia. Though there is hypoxemia to the entire brain, certain areas of the brain are more susceptible to hypoxemia than the other parts of the brain. The areas which are more susceptible to hypoxemia are, one, the hippocampus. Since hippocampus is more susceptible to hypoxemic changes than the other parts of the brain, hippocampus gets affected, and therefore person who recovers from hypoxemic encephalopathy usually will have memory disturbances, because hippocampus is responsible for memory, especially the semantic memory and the short-term memory. The second is the basal ganglia and cerebellum. They are also very much susceptible to hypoxemic conditions as compared to the other parts of the brain. And since basal ganglia and cerebellum get affected, persons recovering from hypoxemic encephalopathy, you could see they usually have movement disorders. Third, the cortex can get affected and persons will have the cortical laminar necrosis. And fourth, the border zones between the ACA and MCA, resulting in man-in-barrel syndrome, or MCA in PCA resulting in balance syndrome, we can see it. So not all areas of the brain are equally susceptible to hypoxemia. Certain areas are more susceptible to hypoxemia as compared to the other areas like hippocampus, basal ganglia and cerebellum. So if we have a good understanding of hypoxemia, its pathophysiology, we'll be able to intervene better and approach a person better, and can salvage the ischemic penumbra by thrombolizing the patient with altiplase and tenictiplase. I really enjoyed giving this lecture, and I hope you have also enjoyed listening to my lecture. If you have any doubts or suggestions or comments, please post on to my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.